Welcome to the UIC Alumni Exchange Series. Through our Alumni Exchange Series, we work to bring our alumni and friends a variety of programs and topics so you can explore, connect, and even escape from the everyday with a community of UIC alumni, faculty, and staff experts. You'll hear me say this a few times today, but I encourage you to visit go.uic.edu/alumni exchange for the latest and greatest programming. And with that, I'm excited to start our program this afternoon with our School of Public Health professor, Dr. Katrine Wallace. Dr. Wallace is an epidemiologist and a social media science communicator who debunks misinformation and false claims about COVID-19 and the vaccines. She's here with us today to discuss the differences between misinformation and disinformation and the techniques that are used to mislead people. Thank you so much, Dr. Wallace, for being with us today, and I'll turn it over to you to begin the program.
Thank you so much, Karen, and thank you to the Alumni Association for having me. It's a true honor to be here representing UIC as an alumna. As Karen said, I graduated from the School of Public Health in 2013 with a PhD in epidemiology, and they haven't been able to get rid of me yet. I have a teaching appointment in both the Epidemiology and Biostatistics Division and the Community Health Science Division. And I've been working during the pandemic as a science communicator on social media, and that's enabled me to do some cool things. I've joined a couple of science communication teams for the UN Verified Initiative and the WHO. I was invited to participate in the G7 Vaccine Confidence Summit in 2021, and I've just started working on the misinformation toolkit from the HHS Surgeon General Initiative on Misinformation. So being a science communicator has opened up all kinds of really interesting doors for me. And you'll see during this presentation, a little bit of my story will be peppered in to the presentation because it's kind of impossible for me to tell this story without some personal anecdotes. So I will get started. Hang on, I'm gonna stop and start again. I don't know what's going on. I seem to have oh, there we go. Sorry, I don't know what was going on. So I'm in my presentation today, the objectives I want to accomplish. I want to talk about the difference between misinformation and disinformation, talk about particularly social media algorithms and how they work and how they provide a breeding ground for misinformation online, and talk about this co-epidemic that we have of misinformation alongside the COVID-19 pandemic and how social media has been used to weaponize health information. I don't know why oh, there we go. All right, so the difference between misinformation and disinformation, now these are used often very interchangeably by people, but they actually are different things. And the difference is the intent of spreading the information. So they both involve the sharing of false information, but misinformation is unintentional mistakes such as like inaccurate information, your aunt sharing a meme on Facebook because she thinks it's correct, because somebody she knows shared it. But there's disinformation where this kind of all originates from, and that is where people plant intentionally wrong information for personal interests such as financial gain, political interests, or some kind of personal benefit. So that's the difference, and the difference is the intent, and it's kind of important to this conversation. There seems to be sort of a delay when I skip slides, so I don't really know why. Sorry, I don't know what's going on.
It was on lunch hour too, so it's just messing with you to move.
I don't know why it's not changing. I'm really sorry, guys. Okay, now it's Okay. I don't know what's happening. I'm so sorry. So belief in COVID-19 misinformation is more common than we think. So nearly 8 out of 10 people believe or are unsure of a falsehood about COVID-19 and the vaccine. And this is not just people that would normally be influenced by this kind of information. It's a representative sample done by the Kaiser Family Foundation of their patients. So that's pretty scary that about 80% at least think one of these misconceptions is true. Okay, and about half of people now get news about the pandemic from social media, which is slightly down in 2021 from 2020, but it's a lot of people solely get their news from social media. And social media users are more likely to believe false information per this poll. More people that get their news from social media are believing the misinformation. So it's a big problem. Okay. So my story is that I became an accidental science communicator. I downloaded TikTok because of the same reason everybody else did. I was bored during the lockdown. And then as I was looking through the content of people's dogs and their food, I was also seeing conspiracy theories at that time that COVID-19 wasn't even real. And so as an epidemiologist and someone that understands the data and was reviewing the data regularly, I was sort of motivated by some sort of sense of duty to start counteracting the misinformation I was seeing online. So before the pandemic, in pre-2020, historically, people involved in communicating their own people were mostly involved in communicating their own science work. So any kind of science communication that you were doing was mostly about something that you were working on in your own lab or with your own research partners, and presenting your own latest data to the public, like at conferences or journals, interviews, or such. And in my case, a lot of classroom teaching. So people generally relied on the media or their own doctors for health information. So 2020 and beyond, there started to be a need for more science communication because there was a lot of urgency with the pandemic, changing policies, and the volume of data that was kind of flying around was very hard for the public to sort through. And so debates that usually happened between scientists behind closed doors were kind of happening in public, right? And so politics, opinions, misinformation, and this whole culture of alternative facts started to emerge. And so in 2020, science communication became important because scientists and medical professionals became kind of these trusted voices, because a lot of voices people were used to listening to had kind of become untrustworthy. So that brings us to social media for science communication tool. And there's pros and cons to it. And the pros are that for public health, it's great because it meets people where they are. That's one of the main things we try to do in public health. It's a great modality to communicate data and information to many people quickly and accurately. And it also makes important information fun, or at least I try to. And some of the cons to it are that attention spans are short. People are just scrolling, and if you don't catch their attention right away in the first couple of seconds, they'll just scroll past. Another thing is the algorithm-driven platforms, which I'll talk about more in a couple of slides, and how that manipulates the data a little bit, what people see. And then also harassment. Anytime you're talking about vaccines on the internet, you will get a lot of negative attention. Okay, so social media algorithms are the first problem and sort of the first barrier to good information that people have. And so these are just sort of things that I have noticed in my kind of social media science communication journey. So the social media algorithms work by engagement, and that engagement drives how often you see specific content. So somebody who likes cats and likes pictures of cats will see more pictures of cats in your feed. That's just the way it works. And so someone with anti-science engagement and likes a lot of conspiracy theories will continue to be shown anti-science content. So the algorithm-driven platforms are just designed to keep people on the app. That's all they want to do. So they favor sort of sensational viral content. So anything that's going to like get a lot of likes and shares and engagement, that will end up going viral. And so in this kind of culture and context, misinformation very often will win over evidence and data. So that is the first kind of issue. And in fact, there was a study by the Washington Post that misinformation gets 6 times more clicks than actual real news. And this was about the election, but it sort of fits in with what I'm talking about, that social media algorithms really fuel the spread of misinformation over more trustworthy sources. The second problem is that we are very bad at assessing risk. Right. So this was the second kind of issue that was swirling around at the beginning of the pandemic, is that humans are bad at assessing risk. So they like to think of the risk of COVID-19 as low. You know, you hear this 99.9 survival rate. And then the risk from the vaccine, on the other hand, is perceived as high. And people think they're hiding deaths and all these like secret adverse events that aren't being disclosed to the public. And then we also have a nature bias or a naturalistic bias, where man-made risks are perceived as worse than natural risks. And then we have an optimistic bias of what our real risk is. Like, people think their own risk is less than that of other people. And you hear all the time, everybody, I don't need a booster, I'm young and healthy, right? Everybody thinks they're young and healthy. Okay. So the problem number 3, the other problem, is this thing called the illusory truth effect. And this is really kind of a spooky thing where it describes how when people hear the same false information repeated over and over again, they often come to believe it's true because their mind keeps seeing the information. And this happens even when people initially know the information is false. So as you can well imagine, social media with its meme sharing is the perfect breeding ground for this illusory truth effect to take hold. Okay, problem number 4, science literacy. So this was another one that took me by surprise because I'm used to teaching graduate students, but science communication with non-scientists had its own interesting challenges. So I made a series of videos in 2020 just on very basic science concepts, like, you know, levels of evidence, because people would send me like a case study of like one person and then trying to argue with like a clinical trial from New England Journal of Medicine and not understanding that those two pieces of evidence are not equivalent. And then different study designs, like you can't make claims off of certain study designs to say certain things. So it was very interesting. And so also just because we're saying different things now than we were in 2020, it doesn't mean people were lying before. It just means that we've collected more data and the body of evidence has kind of moved on. There was a lot of that kind of misunderstanding. So I made a series of just basic science videos so I could tag people in them that were confused. And that was very alarming to me. So in summary of all those things, in 2020, Americans especially were very susceptible to this epidemic of misinformation because we had this public discourse that had very loud voices that were not science voices entering the discourse. We had a poor science literacy problem. We had social media algorithms that were kind of working against real information. these kind of cognitive biases that people already had, and also that were being fueled by this illusory truth effect of seeing the same misinformation over and over again. And lastly, this poor risk assessment that we have. So these all kind of converge and really influence individuals' beliefs about the pandemic. And vaccine misinformation is kind of where this is all headed. The whole, at first it was COVID is a hoax and it's not real, the COVID denialism, but now it's mostly around the vaccine misinformation. And this co-epidemic of misinformation has led to distrust of public health recommendations and vaccine hesitancy. And as a science communicator on social media, there's a continuum with these two boxes of people that refuse all vaccines, no matter what you say or do, they will never get one. And then there's the other side, vaccine adopters. These are the people who are at CVS the day after the CDC approves your age group, right? I'm not talking to either one of those groups in my videos because there's really not much I can help them with. I'm talking to the people in the middle, in the arrow, and that's a very heterogeneous group of people that are vaccine hesitant for all kinds of different reasons, misinformation just being one of them. So misinformation about vaccines, however, is causing people to question getting it and delay vaccination, and this is costing lives and is slowing our recovery from the pandemic. So I feel that good science communication in my job is sort of to be a liaison and build trust and listen to concerns of hesitant people and kind of correct the misinformation in that way. And so in public health, we like models. And so I'm just going to simplify this really quickly. We want to change behavior, right? So there's influencing factors, and then there's, all kinds of things in the middle that people believe. So there's the perceived susceptibility, like how susceptible am I to COVID? There's the young and healthy issue. Then there's their perceived severity, like I won't get really sick because I'll be fine. Perceived benefits of the vaccine, like this will help you not get sick and get severe disease. Perceived barriers, and then self-efficacy. We want to make them feel better about getting it, right? So all of the things we do as science communicators are trying to work on these things so we could get to the individual behavior of vaccination. And so, like I was saying at the beginning, like our list that we just had on that previous slide of the inputs was just like age and, but we know that drivers of false beliefs are much more complicated, right? We have all kinds of things that kind of converge, and we also have beliefs that are already on file. So when we are confused or scared or not understanding something, we will go back to these kind of base cognitive beliefs that we have. And so cutting through all of that plus misinformation is kind of what we need to do in order to get through some of this vaccine hesitancy. So now I'm going to shift and talk about some techniques of science denial that are used by disinformation spreaders to mislead the public with misinformation. And these are sort of the main ones. There are more, but in my experience of debunking misinformation, which is a lot of what I do on my channels, these are the main ones I've had to talk about. So conspiracy theories, we've kind of touched upon a little bit already, but this is kind of how I got my start. We're seeing, basically those are theories that explain a set of events as the result of some secret plot by conspirators, right? So the first one that I had to encounter was that all the COVID deaths are being miscoded, that there's some kind of new world order or a deep state, and that they're trying to trick us into thinking there's a pandemic. So my very first, this was driving me crazy. So my first video that I ever really made was the one in the front where I was just walked through how they code death certificates for COVID-19. And that got a lot of attention, which was surprising to me. Why, if you told me like a year before that I would be walking through how to code death certificates on the internet, I would not have even believed you. But a lot of people really liked that video. And then I kind of took it a step further and kind of talked about how we know these aren't fake because there's excess mortality, which means there's more mortality in 2020 than there was supposed to be. And in a population of 330 million people, we're really good at predicting mortality. So those kind of things are what got me started doing this. And here I am 2 years later, still doing it. Another one, cherry picking. This is extremely common. And this is an example from mainstream media where it's the news headline says, Israel says Pfizer COVID vaccine is just 39% effective. And then that's all they talk about. But this is when data supports a particular position or a controversial one and ignores like a body of evidence, right? So I made a video showing the 39% and then showing that we have this body of evidence now, and that it's very easy to have different data points for infection rates because measuring infection is based on people's behavior and testing. So it's not that easy to just say, oh, it's 39% effective. Much more reliable endpoints are the severe disease, hospitalizations, and deaths, because there's an actual record of those instead of people's behavior opting to test or not. So a lot of people are missing the nuance in the headlines, and then this 39% was then, of course, proliferated online that the vaccines are not effective. So fake experts is another one. It's obvious that people are wanting to hear information from experts, but lay people oftentimes lack the knowledge to know whether someone really is an expert or not. Just because someone's name says doctor, we've had some people, standing up and making YouTube videos and they're Dr. So-and-so from Oxford, but it was like a PhD in education from Oxford, Ohio. But people don't know that, right? Because they're not in the field. So oftentimes fake experts and people that have these kind of conspiratorial videos, they will have secrets the government doesn't want you to know, claims that they're being censored. That's very common. Miracle cures, oftentimes that they sell. Anecdotes, oftentimes anecdotes, no like actual real data. They're just stories that will appeal to emotion. Pseudo medical jargon, which sound real, but it isn't. Then they always refer to YouTube videos or Substack blogs or something like that, but no published peer-reviewed evidence. And they claim mainstream science is intellectually compromised, that people pay for peer review and all this stuff. Like I've heard all of them. But the bottom line is none of these people really have any data to support their claims, not even one case study usually. So that's a very common one. So then there's coordinated disinformation campaigns, which I've seen, unfortunately, a lot of during this pandemic. This is oftentimes disinformation spreaders will purposefully plant bad data in either a very low tier journal or a preprint server, which is now being used increasingly, which is a server that you're supposed to put a paper on that's being peer reviewed. But a lot of these have no intention of sending their data for peer review because it wouldn't pass that. But their purpose is to cause confusion and chaos, in an already bewildered public, and they're very successful in doing that. And so this is an example of a person that reanalyzed some CDC data to show that the vaccines are causing miscarriages, which, then the arrow just points over, it got picked up by this fake news website, basically like a propaganda website. And then of course, proliferated, that link from that website got proliferated on social media. But the reality is on the bottom that the CDC has issued a health alert that pregnant women should get vaccinated because it's, definitely serious health risks if they don't and they get COVID-19. So this one was particularly egregious. Okay, appeals to fear. A lot of what I do is debunk misinformation from the VAERS database. So VAERS is the Vaccine Adverse Event Reporting System. And I could do an entire talk just on VAERS misinformation, but basically they, anything that happens after a vaccination you can log into VAERS. So there are things in there like person got COVID-19. Obviously that's not from the vaccine. There's car accidents in there. There's anything that happens is fine to put in there. And epidemiologists that work at the CDC and the FDA will look at this data constantly and look against the background rate of what's really happening with, in the background rate of the population, and see if the events being reported are in fact increased over the background rate. And that is how they found the myocarditis. That is how they found the blood clot issue that was happening at the beginning with the Johnson & Johnson vaccine. This data is being mined constantly and paid very close attention to. But of course, people who don't understand that process will look through VAERS and pull out all kinds of unrelated stuff, or, we always say correlation doesn't equal causation. Just because it happened after the vaccine doesn't mean the vaccine caused it. And in fact, the appeals to fear are very, very common on social media. This video on the right-hand side of the screen, by the time I screen capped, it had over 11 million views, and this woman had a GoFundMe to help from her vaccine injury. And in fact, this was all determined to be a fraud, and GoFundMe actually refunded all of the donors because this was not real. So these algorithm-driven platforms will push these videos out, as you can see from the amount of views this one had, and it becomes viral misinformation. And seeing something like this, if you're vaccine hesitant, really has an effect on you. And so with the United Nations Verified Initiative, we have this misinformation is dangerous, take care before you share. And we also have verify before you amplify, to try to get people to really make sure that the things that you're sharing on social media are in fact correct or real, because there's a lot of fake stories. Also, another thing is logical fallacies, and I'll go through this quickly because it's kind of complicated, but basically the base rate fallacy is very common when people want to spread vaccine misinformation. And it's that in a highly vaccinated population, if you're just looking at the numerator of events, you're not going to get the real rate of how often, of the real vaccine effectiveness rates, right? So like a perfect example is the middle news story is like when we had that outbreak in Cape Cod and Provincetown, Massachusetts last year, it was like, oh, the study shows 74% of the people were vaccinated. So people just jumped to, oh, the vaccine doesn't work, right? But this is an analysis I did for The Hill. Basically, on the left is, if we just look at the raw numbers of events, this is Israeli data. The green line is the vaccinated people. It looks, without adjusting it for how many people are vaccinated, if you just count numbers of events, yes, it looks like there's most of the events in the vaccinated group. But you got to take into account that most of the country was vaccinated at that point. So if you do adjust for that rate on the bottom, you can see that the vaccinated group is basically almost zero risk of severe disease, and there's a huge delta between who's vaccinated and unvaccinated. So that's a trick they like to play. Another one, impossible expectations, or black and white thinking, I like to say, is they use something not being perfect as a reason to just dismiss solid evidence. And you hear it all the time: masks don't work. Breakthrough vaccine cases means the vaccine doesn't work. But in truth, no mitigation or medication, for that matter, is 100% effective. And so what I like to say when I'm addressing these kind of questions is I like to look at this Swiss cheese model at the bottom and just show that in times and areas where the transmission is high, we like to use more layers. And when it's lower, we can pull layers back. And that's why you hear like the city of Chicago or the state of Illinois, like they require masks at some point, and then you can take them away. This kind of thing, they will add layers when layers are needed and take them away when they're not. And that's because none of these layers alone is 100% effective. And the more you layer up, the better you are. And I saved the best for last. Whoops, false balance. Sorry, I don't know what is going on. When a scientific issue is settled, a lot of times people like to present sources from both sides as if the scientific community were split on the issue. And this is very misleading to the public. And some of you may remember a bunch of my colleagues and I wrote a letter to Spotify in January because they were allowing their largest content creator, Joe Rogan, to put misinformation on his show. And at the point when he had like, 11 million subscribers or something, and he was, having guests on there that were promoting just baseless conspiracy theories about the vaccine. And so we did this letter, and basically the gist of our argument is that they are creating a false balance by having these, things that have been proven to be false on this huge platform. And it's very misleading to the public, and makes this kind of illusion that the scientific community is split on the issue, when in reality, it's been proven that the vaccines are safe and effective. So that got a lot of attention back in January, but that was an example of false balance. And so who is doing this? The Center for Countering Digital Hate, which is a great not-for-profit group that does a lot of research about the internet and things that get shared on the internet. They mostly deal with hate against targeted groups, but they did a lot of things on the anti-vaccine movement also. And they found that in their research, the Disinformation dozen, which are listed here on this slide, are responsible for originating at least 65% of anti-vaccine information online. So these are people that are profiting off the pandemic by spreading misinformation. So their social media pages kind of serve as a storefront. There's a link in their bio where you can go in and buy books and coaching and supplements, beauty products, telehealth, non-evidence-based treatments for COVID. And this is a really huge industry, and they don't even need a sales force to sell their products, because people share their misinformation memes and posts for free. So it really reminds me, on the left side of the screen is the snake oil salesman from the 1890s. And I would be remiss if I did not mention America's Frontline doctors, who sell telehealth visits for non-evidence-based treatments for COVID-19, like hydroxychloroquine and ivermectin. And there's a group called No License for Disinformation, which is in the front here, that are trying to alert medical boards to these kinds of doctors that are not treating per the guidelines and are selling non-evidence-based treatments that don't work to patients to profit. So misinformation about COVID-19 and the vaccines is a huge public health problem, because it actually kills people. And you see these news stories all the time, like, people saying their mom died of COVID, but it was really the conspiracy theories. They were sucked into the rabbit hole, and these are, now I'm appealing to emotion, but I actually have data. So you can see that the vaccine was authorized in December of 2020. And by May of 2021, the vaccine was widely available to adults in the US, but yet we still had this trajectory of deaths, and hundreds of thousands of people have died since the vaccines were available. And in fact, just last week, and I was very happy to see this slide, a research study from Boston University modeled out how many vaccine preventable deaths there have been during this pandemic since the vaccines have been available, and they've gotten it almost to 320,000 vaccine preventable deaths if all adults had just gotten vaccinated when their time had come. So 30% of the eligible people 5 and above have not been vaccinated yet, which is a lot. And you can see here, just getting 2 doses of the COVID-19 vaccine reduces your risk of dying by 10 times. And getting the booster saves even more lives. And 50% of eligible people have not yet gotten their 3rd shot of COVID-19 vaccine. If you do, you have 20 times less chance of dying from COVID. So in conclusion, misinformation and disinformation is very prevalent on social media. There's definitely a need to counter bad information with good evidence. Social media algorithms, as we discussed, provide fertile ground for viral misinformation to spread. There's a co-epidemic of misinformation during this pandemic, and social media has been used to weaponize health information for nefarious intent, profit, and agenda setting. So I'm sorry about the technical problems I was having, but I am open for questions if you guys have any.
Well, thank you so much, Dr. Wallace. This is just great and wonderful information. We did have a couple questions come in, and I'm going to start out with what I think is a big question. So the question is, please discuss the confluence of media outlets and political figures in contributing to misinformation, as well as their motivations and role in spreading misinformation.
Yeah, so we've had a lot of problems with that. So it's social media is one kind of part of the media, right? But there's mass media too. And in particular, Tucker Carlson has been kind of setting the tone for a lot of the, anti-science, anti-vaccine, misinformation on a large platform, similar to Joe Rogan, really, because he's got a lot of viewership, just blatantly spreading misinformation. And then what kind of comes from that is the people that watch that channel then kind of use that, and there's a lot of what we call anti-science aggression against us because they feel empowered by the information that's shared on these big channels. And so that has been a big problem, and I think it's definitely contributed to that delta of the 319,000 preventable deaths. Absolutely. So social media is just one part of it, but that's your commenter's question is a good one. Like, there is definitely a huge influence of the mass media as well.
It could be probably a whole nother presentation looking at mass media outlets and just the influence. Thank you. Another question is, do you distinguish between dying with COVID and dying from COVID? And what are hospitals' financial incentives to code deaths in a certain way? I think this came when you were showing your TikTok.
Right. So this is part of the COVID denialism conspiracy theory world. I get this question all the time. And that's why I did the video of this is how we code death certificates. If somebody dies and COVID-19 is on the death certificate, and so death certificates are often, you have to establish a kind of a pathway of how the death occurred, right? So if somebody has cancer, they don't write cancer as the first cause, it's something else, and then cancer is the underlying cause that actually led to the death. So on a death certificate, you can very easily see that there's COVID-19 could be like the third cause, then ARDS or some kind of pneumonia or some kind of other cause. So just because COVID is not the very first cause of death on the death certificate does not mean it is not a COVID death. And I know that was one of the actual coordinated disinformation campaigns that we had early in the pandemic, which obviously is still widely believed, if I'm getting this question today, is that only 6% of the deaths were truly COVID, because somebody went on the CDC website and looked to see what deaths were with nothing else on the death certificate, and they thought that was the only true deaths were those, and the rest of them were all from something else. But you look and see kind of the constellation of events that caused the death, not just COVID. So yes, these are COVID deaths. And we, in fact, in JAMA, there was a death certificate audit that was done, and they found that like 96% of the COVID deaths that had been logged in 2020 they all had a pathway or a constellation of events that made sense for COVID. So I'm not worried about miscoding deaths.
Thank you for that clarification, because I don't think, unless you've really looked at death certificates, I think that pathway is a really great way to explain, because it is true that you don't just list cancer to your example. It is really, this is what led to, and that is something I don't think people always understand. So thank you for that clarification. Another question. What implication does the COVID-19 misinformation spread have on future public health crises? There's a second part. And what would you recommend to combat the issue early on and efficiently?
So I'm working with, I mentioned at the very beginning, is that I'm working with HHS on a community toolkit to address health misinformation. And I'm not sure, we're sort of talking about how we're going to disseminate it, but it's meant to be an education for lay people in health misinformation. And we have a slide deck pulled together, and we're trying to figure out like how to disseminate it best through either health departments or public forums or something. But yeah, it's definitely a huge problem, especially because people are profiting off the misinformation. So there's really not a big incentive for people to stop doing it. Another thing that would be helpful is there's actually legislation in place right now that sort of protects the platforms, the social media platforms, from being implicated in the spreading of misinformation. The FCC regulations right now say that they're not responsible for things people put on their platform. So as you know, they can just be like, well, we're just, you know, here to provide the hosting. You know, what gets put on our platform is not we're not liable for, and that's actually true. So that legislation we've outgrown, because that's from 1996 and really was for like chat forums and comments. Like, this is definitely, the landscape has changed, and the legislation needs to change too. And that's why that so many hearings are being brought to Congress, where the actual social media platforms are asked to testify to their role in facilitating misinformation, because it's just very obvious that they could be doing more than they are.
Thank you. We had another question. Who creates social media algorithms?
So it's very interesting. The programmers that work at like Facebook, which is now called Meta, and TikTok, and these are all proprietary. We don't get to know how they pick everybody's algorithm is tailored to you. So you start liking things, you start interacting with things, and then it starts to know you and starts to feed you information that it thinks you want to see. So I guess it's just programmers that kind of work behind the scenes, and we aren't privy to how they do it. But it is kind of like we were talking before this call, a bunch of us, about how it's spooky sometimes, the things you see. Like, you'll be talking about something and then it'll pop up on an ad on your computer, and you're like, how did it know that I was just thinking about that or something? So it does know things, but we don't really know what the algorithms are.
It goes back to the whole idea that just because you saw it on the internet doesn't mean it's true.
Oh gosh.
You should question it, which actually leads well into the next question, what unbiased data resources can someone use when trying to share validate information with their loved ones?
Yeah, that's a great question. So I would say there's lots of information that's written for lay people on the CDC website and on the WHO website. In the US, I would use the CDC. You could, if you're looking for like rates of disease, like, you know, what your risk is right now, then a local site like Chicago Department of Public Health or Cook County, Illinois, those are better than looking at the US, because a lot, you know, risk of COVID is local. So I would caution against, like, when you hear things like, oh, we're having this many cases in the US today, like, it may or may not apply to you locally. So it's better to use your local public health department in terms of incidence data. But yes, those real public health sources are better than just things that you're seeing shared on social media.
Well, and thank you for the distinction between local and also the CDC, because the CDC really was polarized during lots of parts of the pandemic. And so I know people started to mistrust, and there was all sorts of feelings around that. So I think really those local sources is an important part, because it is different what happens in Chicago versus wherever else. Another question: do public health departments and other public health authorities who participate in sharing misinformation or disinformation, and if so, how do we combat it? So do public health departments or other authorities participate in sharing misinformation or disinformation?
I wouldn't say on purpose they do. I haven't seen any examples of anybody from public health purposefully spreading misinformation, but a lot of times, you know, information that we share becomes obsolete because we find more data down the road that is better data, or we study something and find different conclusions, or most often in this pandemic, the virus mutates, right? So the virus changes, so then we have to adapt. so this is a lot of what I do, is kind of try to explain to people that no, we weren't lying before. No, we did, the vaccine was 95% effective. It doesn't mean that that was a lie before. It just isn't 95% effective against BA.2 that we have circulating now. So a lot of that isn't misinformation. It's just people misunderstanding how fast the landscape is changing.
Thank you. Do we know, or do you know, was there misinformation during the 1918 flu pandemic? Is there anything?
There was, and there was anti-maskers too.
Wasn't that funny?
Yep.
Was there things that we learned from 1918 that then applied, or is it
It doesn't
just
seem so, does it?
It's interesting, in a different conversation, there was the idea that as parents, we can't tell our children this is how we lived through this before, because it's really been such a long
Yes.
time of how people dealt with things. A bit of a personal question for you. We know that you chose TikTok as the platform that you were on. What made you choose TikTok over other media platforms as sort of your primary info? Is it to attract a younger audience? Is it?
That's a great question, because the different social media platforms do have different demographics. I used to go into that in this talk, but I took it out for time. But I do it on all of I post my videos on all the social media networks, but TikTok is, because of the TikTok For You page, they have a very unique algorithm where you don't need to be following the person to see their posts. So if they'll just feed you videos they think you're going to like. Whereas like Instagram and Facebook, I think you have to be following the person first, and then so it's very powerful platform, because it's easy. I grew a following pretty fast on there because of that. Like anybody that was interested in public health or epidemiology or COVID just started getting my videos in their feed. So I think why that's my largest platform.
So do you see whether it's TikTok or another social media platform really growing as a way for us to, not only for epidemiologists maybe to study, but then also for us to get information out there? And I think this is a complicated question, right?
No, I think it's a good question, because we're trying to figure that out now, right? Because so public health departments have been underfunded for decades, right? And they really they're not really on the cutting edge of technology, right? So a lot of, like, I got invited to talk to APHA last year because I was doing something that they viewed as sort of novel way to disseminate information and meet people where they are. And so that's what this community toolkit that HHS is trying to put together is, like, sort of just trying to meet people where they are. And we're trying to figure out if we can do a social media component to that, or so yeah, I think ideally every health department needs to interact with people and answer their questions. And that's been something that I feel Allison Arwady in Chicago, Dr. Arwady, has been very great at doing. Every week she has a Q&A session and she answers people's questions, no matter how trolling they might be sometimes, but she's very open to that. So I feel like every health department in a situation like this needs to be doing that. And so there needs to be like a million of me.
Right. Well, exactly. I mean, another question came in about many people don't want to read long dialogues about issues. And so how do you address this? I think social media, because it is that really quick sort of burst of information, if you will.
And I do actually view my role as sort of a liaison between the scientific literature and the latest data that I'm constantly getting in my alerts, and lay people who are just trying to make the best decisions for themselves and their families. And I feel like if they hear it from me, getting it from the if they're using data to empower their health decisions, that's filling a void that would otherwise be filled by misinformation.
Thank you. Another question is, how do you adjust for misinformation versus misunderstanding?
So that's sort of the difference between misinformation and disinformation, right? So there's like the person that plants misinformation on purpose and wants to mislead people. And then there's like somebody that just shares things, not really understanding that it's not accurate or correct, right? So I think it's just the intent is different, but it still has the same effect, unfortunately, right? Because if I forward, an infographic that has all wrong, misleading information, then everyone in my feed sees that, right? So it really doesn't, it's a different intent, but unfortunately has the same results. So that's why it's a problem.
And there's the space of just human error too, where somebody
Yeah,
reads
for
it,
sure.
they read the wrong
Yeah, I
word.
don't think most people mean to spread misinformation, but people just forward things and that's what happens.
Right, right. Sort of along the same lines, are there any ways to take the responsibility for identifying false information off the individual?
So that's what they try to do. We're trying to get the social media platforms to be better about enforcing community guidelines. And it's been a mixed bag of success, I'll say that. Some platforms are better than others. YouTube is one of the better ones. It keeps up with the scientific literature, and it will take people off their platform if they repeatedly, like for example, Dan Bongino, who's a Fox News personality, was consistently making videos about how masks don't work, and he lost his channel because there is a specific guideline that says you are not allowed to say that masks are not effective in reducing transmission of COVID-19. Like they have a specific guideline. So they're better than most, I would say, but that's why we wrote the Spotify letter back in January, because Spotify had no community guidelines for their creators. They had no public way of moderate. There was no policy posted where they discussed how they moderate misinformation on their platform. So that's all we were really asking them to do, is to institute a policy, because the information that was coming out of the Joe Rogan podcast was extremely damaging.
It's really interesting because it could be a whole nother presentation, right? About just I'm sure there's people that have the freedom of speech side of it, and then people that are saying, but you have to get the public health side of it, saying, how do we keep people healthy?
Yes.
And so that could be probably a whole nother discussion.
I was on many conservative news show where that was the theme. Why am I trying to restrict people's free speech? And what I would say to that question is that, when something is, we're in a global health emergency, and these things that we're talking about have been studied, considered, and proven to be false. So it is not freedom of speech. You don't have the right to endanger someone's health. When it's not, it's been proven to be false. It's wrong. It's just like yelling fire in a movie theater.
Correct.
It's the same
You're not allowed to
principle.
do it, right? Exactly.
Mm-hmm.
Final question, and thank you for all this wonderful information and conversation. With the current variant and surge that we are seeing right now, what information do you feel is crucial for everybody on this call right now to have?
Well, I think so. The CDC changed the way they report out they have now moved to community levels, which more is not really primary prevention anymore. It's looking for severe disease and are we overwhelming hospitals in order to recommend masks and things like that. And they, in a post-vaccine world and where we have some treatment, they felt that made sense. If somebody still wants to protect themselves, I would definitely just look at the case numbers and the transmission. Right now it's high. In Chicago, it's high. And so I'm recommending that people, test before you gather with people, have graduation parties outside, wear a mask if you're indoors, and avoid indoor crowds. And of course, get vaccinated and boosted if you aren't already. Those are the things that I'm because transmission is high. And so that's what I'm recommending to people on my channels.
Great. Thank you so much, Dr. Wallace. Thank you for this wonderful presentation and conversation and for all this great information. I did have a couple people ask if we would have the slides and the presentation available. We will on our website in a few days. So
and I apologize again for the technical issues. I have no clue what was going on.
It's the Zoom world and just how technology, sometimes it's our friend and sometimes it likes to test us. So no, but thank you so much. We're so grateful that you are an alumna and a wonderful faculty member and for all this incredible work that you are doing. So thank you for being with us today. Just to quickly close this out, please join us on June 1st at noon Central Time for our next Alumni Exchange program. Screening job candidates is becoming increasingly automated and sometimes performed by artificial intelligence tools. Two-time alumnus Alan Jones will join us to discuss the background dynamics of AI interviews and how to best prepare for them as he presents how to master AI based interviews. You can also find a copy of this recording, as I mentioned, on our website, and please be on the lookout for that quick survey that I mentioned at the beginning. We really appreciate hearing your thoughts and opinions. Thank you again, Dr. Wallace. This has been a wonderful conversation, and thank you for sharing such good information with us today. We hope that the rest of you have a wonderful rest of your day, and we look forward to seeing you at a future UIC Alumni Exchange. Thanks again and have a great day.